Good afternoon, ladies and gentlemen. My name is Stefan Windecker, and it's a pleasure to welcome you to this afternoon symposium, which will deal with imaging and innovations related to imaging-guided interventions. I'm very pleased to do this symposium together with my colleagues, Dr. Amabile, Dr. Asami and Dr. Pasupati, and you will see there will be a series of presentations that will touch upon different interventions, but using one common system, and that is the angiographic system provided by Canon. And I also need to disclose that this symposium is sponsored by Canon. So, without further delay, I would ask the first presenter, Dr. Amabile, to present on dose reduction tools and intuitive workflows.
Thank you, Stefan. So, dealing with dose reduction, it might not be so sexy, so I propose you just to illustrate how we use the Alphenix system in our daily practice, in our cath lab, for a complex case of CTO. It will be a live-in-the-box presentation that will illustrate the current options we have, so that's the present, and maybe further during the symposium we will illustrate the future of what's going on. So keep in mind that this is not something that is, we won't have to discuss the technique, but rather just an illustration on how you can integrate different systems in an integrated workflow to get a better treatment for your patient. Can we have more sound, please?
And Joanne. And Dr. Masahiko is going to introduce you the case.
Good afternoon. So it's a case of 56-year-old man with risk factor diabetes and hypertension. He has a PFO with previous ischemic stroke, and we discovered a stable coronary artery disease after he had an angina and with dyspnea. So he had a coronary CT scan that showed severely calcified LAD lesion with significant stenosis of the RCA also. The TTE showed anterior wall mild hypokinesia with LV ejection fraction about 50% mildly reduced, and the coronary angiography showed a long CTO lesion on the proximal LAD with a GCTO score about 2 with ipsilateral entrop 3 flow, and mid-RCA significant lesion. So he had a stress test that showed positive. It was positive electrically and clinically. And after discussion with the heart team, we decided to do percutaneous revascularization. Next, please. So we decided to start with the LAD lesion, the CTO1. If we succeed, we will proceed for other lesions. So our strategy today is to have a double radial axis, left and right. The main radial axis 7 French on the right side to the antegrade, and with ABU 3.5 guiding catheter, and the contralateral axis 6 French on the other side, on the left radial. We will do, our strategy is wire escalation. We'll start with the Fredericks T maybe, and with microcatheter support. And after that, we will do a preparation of the lesion with rotational atherectomy plus minus intravascular lithotripsy. Our procedure will be guided by IVUS, post-disocclusion for analysis of the lesion, the length, the diameter of the artery, and the guidance of if we need left main PCI because it's an ostial LAD lesion. So for you, Nicolas, to start.
Yes, so today we really would like to show you how we use all the features from the Canon Alphenix system to help us in this kind of very complex cases. So we're going to start with a control angio. So you see it's really a very tight calcified lesion. It's a CTO. And we have very few contralateral flow, but we have a good ipsilateral flow. So as mentioned by Ella, we're going to start with a conventional antegrade approach with escalation, wire escalation. We're going to keep an eye on the radial dose, as you can see on the screen. So we have this dose tracking system that will help us to get a good view of what we have. and then we're gonna use the IVUS. So I propose to switch to the SpotRoy system mode. That is a really nice feature that allows us to decrease the dose, and you will see that the image is only focused on the region of interest, like this. And I think we can zoom.
Okay.
Sinon, si ça passe pas. Vous avez le feeder, les gars?
Yes. Je pense. Yes, double S-curve.
Double S-curve.
Yeah, good.
C'est pas mal ça.
Yeah, good.
Test?
Yeah, good.
C'est pas mal ça. Si on est capable. Graph. Yeah.
Okay, we are 70.
Not bad. Well,
We are 70. But we can do a puncture. Getting very well.
Memoscope.
Oh, that's it. It's done.
Okay.
Okay.
Let's
Do you want to advance the microcatheter?
let's check the position, but it looks good. We have no.
Okay, I will do a retro injection.
Yeah.
Great.
To me, it looks good.
Yes.
Now there is a. Yeah. We put the SpotRoy and we slowly advance our Corsa Pro.
Okay, I will open the. I would like to show the distance of my wire.
Yeah.
So.
You can move to the larger field.
Yes.
The 20. Keep the SpotRoy.
Okay, great.
And you see that really the Warota wire is very distal, so we're gonna have a lot of support, which is good. And Ala is slowly removing the microcath from the LAD.
So we are good to start rotablation. Okay.
So Ala will be in charge of the rota.
Okay.
We're gonna start with a taking motion. Taking. Super.
So we are forcing the lesion right now.
Stop.
So we'll restart.
To save, and you see that's nice because now the wire is really straight into the proximal AD.
Great.
And
Our
the balloon is really
crossing
getting.
very well.
So
I will do some injection to start at the osteum maybe. Okay, that's great.
that's great. Well, once again, we're just talking with Ala, but I think that there is definitely no way to get rid of just to nail the ostium. We'll see, but after the IVUS, but. Once again, I'm not sure. You see there is no residual imprint on the balloon, so that's good.
I'm at 20 atmosphere, so. Okay. We see the calcification around the.
Pas mal, hein?
Yeah. Good. It's opening well.
No residual imprint once again, so that's very encouraging. You will see here that we have some calcification. This is a normal part of the artery. Actually, it looks normal. So the very interesting point is that the lesion looks shorter on IVUS than on the angio. So it will allow us to get a more precise PCI. Now we are really into the CTO. You see, it's really into the calcification. And
we are in the true lumen also.
Still on the true lumen. I just think that at one point we might have get out of, maybe we might be extra plaque. I'm not so sure, so the IVUS will tell us. So far it's still good.
No?
Well,
no, we are enter.
You see it's hugely calcified, but there is no ring. It's cracked by you see that we cracked the thing with the
ring.
Yeah, the ring is calcified. You see that there's these images of abrasion by the
non-compliant balloon.
The non-compliant balloon. I would just slightly.
So we'll come to the osteum, I think.
Yes. everything is really calcified.
So we have the IVUS, the monitoring of the patient, and a bigger view of the angiography.
We can also show how we guide our calcified lesion treatment with the stent enhancer mode from the Canon system on this zoom stent enhancer mode.
We'll zoom a little bit. Okay, great. You can go.
Okay,
Great.
let's go. And we see that we are really past the
Proximal part is very, very calcified. The distal
And
part is less.
It's slightly calcified,
Yeah.
but I would start there.
Okay.
So the stent enhancer mode was not designed to analyze the
there is a
calcification,
lesion.
but rather the stent, but it works pretty well if you
We
want
use
to
the
get
one-shot
a good
mode.
picture of
We
the
don't need to
topography of
record
the
for-
calcification.
Minutes and minutes. So it's a 3.028 synergy X day. It's a good one for calcified lesion. You see it crosses pretty well.
Inflation.
Nice.
I'm at 12.
Donc ça, c'est un 28. Stent enhancer mode, please.
Yes.
Good.
Good. That's a nice
have-
overlap. Graph. Short graph.
Good. We have
It's
8
good.
millimeter on the left.
Yeah, that's. I like it because
If you are
I'm
doing
not
for
really. I'm not really a big fan of covering the ostium of the left main, especially in this case. It's super huge. So let's go. And we can already have our pot balloon, please.
Okay.
Looks
One,
good.
2, 3.
So now there's really a tricky. There's a tricky point because so the pressure is still okay. Okay.
We'll go here.
And let's go. Let's do it. So inflate up to 16.
So I see the recoil of the stand, so the left main is really a large one.
Ok. 2000 de plus, s'il te plaît, d'héparine.
Have the wire. Okay. 3 balloon in place, a little bit more proximal.
I don't know, like, where is it? No.
It's good.
Oh, it's a lady who's
The
now
LED is
completely
not
off. It's the LED balloon is too distal. And that's it.
Okay, we can do a stent enhancer right now to see the LED, the left main stent. Okay, we can get more proximal if you want.
I would probably start like this and
Okay.
then get make a second inflation more proximal
Okay,
if you
we'll
don't
go.
mind.
So
I have the
prepare.
yes.
So 2 atmosphere. Okay, go. 2,
2,
4, 6, 8.
8.
check the pressure, and when the pressure drops,
1,
2,
2, 3. Okay, we don't see the ostium of the ramus, but if we move to this view, I think we will see it. Okay. Okay, great.
It's good. Good
So
one.
we do a cranial for the LED, and after we'll IVUS, or
Yeah. What is really interesting is that you can see these really bright images around the media, and which is a good sign of positive remodeling in the future after your deocclusion. And now that's the sense. So there is no dissection at all.
So that
And
is
you
a
see
real
there's no-
representation of what
as far
you
as I
get
can
in
see-
your
as we
cath
can
lab, and on
see
your screen
here,
you've got the
you cannot
IVUS,
see any
the angio, the dose tracking
malapposition,
system,
but
the
that's gonna be a
reference,
long
and the
run.
EKG. So you've got all the information in front of
I'm
you, and
looking
you can
forward
control
to the result of the
have an eye on
analysis
everything.
and of the post-stenting minimal stent area into the proxial AD to be sure that we can obtain the criteria proposed by the EuroPCR, which are 5.5 square millimeter into for IVUS analysis. Wow, it's pas mal.
6.12.
The question is, what was the size of the balloon that we used for the tracing?
It's a good result.
It's a good result by
I
IVUS.
controlled the distality of the LED because it was under perfuse and direct expand, and
once again, we don't have to be disappointed by the size of the distal LAD.
okay, good. Okay,
I'm pretty confident with the. Maybe I was just the cannulation.
intubating.
Yeah, but once again, let's see, because that's
yeah,
good. Okay, and then we can check.
Okay.
This patient's gonna have a subsequent mid-RCA PCI, and so at this point
We'll check the
we'll
left.
check.
the
But
left,
I'm pretty good,
system.
pretty confident. So I think we're done, guys. Thank you
That's
very
good.
much. Let's remove and thank you everybody, and thank you and have a
We are
good
happy with our
afternoon.
result.
Thank you.
Thank you very much.
So thank you, Nicola, for this very nice demonstration on a complex PCI case, and I think we all appreciate the importance of accurate imaging. If you have questions, please don't hesitate to go to one of the microphones. You can also submit your questions here online. And maybe one feature I would be particularly interested in is this dose tracking visualization that we have seen here on the screen. Perhaps you can tell us quickly how this is operating in terms of color change and so on, which particularly during CTO interventions is obviously of importance.
I think as a CT operator, I was really interested in this feature that is illustrated here on the lower part of the panel, and you can see that in real time you have the dose delivered to the skin of the patient, and you can also visualize the incidence of the X-ray beam across the patient, and you get this nice color map that is a good way to analyze the dose. And when everything is blue, it's okay, and then of course the I would say the most red you come and the worst it is. And so I think this visual representation is a good way for us to get the information and to be able just to change the sometimes you are into your procedure, you don't pay that much attention, and then also the nurses are quite aware of that, and sometimes they say, well, you should change because now the delivered dose is too much.
No, I think this is really a very important feature, not just for the operators, but particularly also for the patient safety. And frequently we also deal with repeated procedures. So I think this is very important. I'm sensitive to time because we have two more presentations, and I propose that we transition to the next presentation, which will be provided by Masahiko Asami, and it will touch upon some deep learning technology that is integrated in the Alphenix system.
Okay, so thank you for kind introduction, Stefan. So good afternoon, everyone. My name is Masahiko Asami from Mitsui Memorial Hospital, Tokyo, Japan. It's a great honor to present real-time AI technology to support complex procedure today. This is my disclosure. Sorry. So I'm going to talk about complex SHD intervention with current technology first, followed by future intervention with AI technology. So the patient was 49 years old female who had developed symptomatic severe aortic stenosis due to a failed bioprosthetic valve and stroke abdominal aortic aneurysm enlarged to 63 millimeter. And she had a high surgical risk with SDS from 8.9% and a critical frailty scale was 1. And her lifestyle was active and independent. She had multiple comorbidities such as steroid-dependent polyarteritis nodosa, myelodysplastic syndromes under treatment with steroid and immunosuppressant, and transfusion-dependent idiopathic thrombocytopenic purpura. And she also had a complex history of aortic surgery. 20 years ago, she had acute aortic dissection at the ascending aorta, and she had undergone ascending aorta replacement. And 7 years later, her aortic root was expanded, and then she had undergone ventral surgery using SEP 25 mm for aortic valve replacement and Hemasil 34 mm for aortic root reconstruction. and get a soft plus 8 millimeter for coronary reconstruction. And then in 2021, she had also distal arch aneurysm, and she had to undergo distal arch replacement like this schema. Then here you can see laboratory investigations. She had a normal liver function and renal function, and a higher NT-proBNP and CLP and D-dimer level, and hemoglobin and platelet was extremely low. The EKG shows normal sinus leads with no bundle branch block. And the transthoracic echocardiography revealed severe aortic stenosis with normal LV and RV function, no pulmonary hypertension, and trivial aortic insufficiency. And then she had no significant coronary artery stenosis, and a multi-slice CT before TAVI revealed enlarged ascending aorta and ST junction, and both coronary height were enough high, and the membranous septum was 11.4 millimeter, and no horizontal aorta. And the perimeter at the annulus was 73.9 millimeter, and the area was 430.8 square millimeter, and the BTCs both are enough long to perform valve-involved procedure. So up shoulder, we can use several type of THV, and then we decided to use evolute valve in this case. And you can see she has a tortuous aorta and a huge aneurysm with dissection. And you can see the dissection at the top of arch, and then huge aneurysm here, and this is true lumen. This is false lumen. And dissection is expanded to the terminal aorta, and this is true lumen. This is false lumen. And then luckily she had a femoral artery, both are intact. And again, I show you the complex anatomy of this particular patient. And then here is a ventral side, and here is aortic arch, ascending aortic replacement, and here is a distal arch replacement. That is here to here is a native arch with dissection. And here you can see detailed image analysis of CT scan. This is true lumen. So the true lumen on the right from my side. And then this is true lumen. And here, so it's a front side. And again, here is a true lumen. Go up. And then this is true lumen, front side. So in our local heart team discussion, SABA cannot be performed first because her aneurysm is about to rupture. So furthermore, it's difficult to perform dissection surgery in the lateral position in the presence of severe aortic stenosis. And it's also difficult to perform simultaneous procedures. So the best option we thought would treat AES first by TAVI, and then treat aneurysm as soon as possible. So anatomically, valve-involved TAVI procedure was accepted, and we had determined to perform valve-involved TAVI procedure with Evolute Pro plus 26 millimeter. After puncture of right femoral artery, I advanced the wire through the true lumen by TTE guidance like this. Here is the true lumen. And at the top of the arch, I advanced the wire by TEE guidance. This is a wire. I try to cross the wire, check the T. And finally, I successfully cross the wire through the true lumen. And this is orthography. Looks not bad. And I used 20 French 65 centimeter long sheets, and I advanced carefully, and it has reached the top of arch. Actually, I thought the sheets would reach the ascending altar, but unfortunately, it was a few centimeters short of distance. And then after that, I tried to advance a THB with some resistance, and then I tried to push it. And then I could deliver it to the ascending aorta, but not to the aortic position, like this. And then that's why I changed the wire to the Landkist, which is a stiffer wire, and used a snare technique, but it did not work. And then as a next step, I used a PTA balloon to support delivery. And then finally, I successfully closed the THB to the failed surgical valve. And the implantation step was normal, like this. And then a successful implantation. This is a final assessment. Aortography showed a good result. And however, in this young female patient, we should provide a specific intervention with less radiation and less contrast media dose as possible for her future. And then after TAVI, she had undergone a graft replacement for thoracoabdominal aneurysm, and she is currently in good health. So in a future intervention with AI technology. In the medical field, artificial intelligence has been bringing about dramatic innovations. Interventional treatment is expected to become much less invasive in the near future through the use of AI technology. However, it has only been used for post-processing of obtained images so far. With the advancement of technology the time has finally come to utilize such technology for treatment in real time. Less radiation dose, less contrast media, more device, and better visibility are expected to be achieved with this technology. So here is a question for you. One of these images is for acquisition, while the other is for fluoroscopy. So which one do you think is fluoroscopy? Maybe you guys left side. But the answer is the right side. As you can see, the noise in this image is very suppressed, and the vessel looks quite sharp, similar to acquisition images. Actually, the light image fluoroscopy was processed with deep learning technology. The complex algorithm established through deep learning by Canon Medical will achieve a sharp image with good contrast, and result in more than 2 times contrast to noise ratio, which is a key metric to represent the quality of the X-ray images. And here you can see this is a comparison between conventional fluoroscopy and AI-processed image. With this technology, you can obtain deeper perception of vessel anatomy and gain better image comprehension in challenging situations like steep angulation and obese patient. Also, as basic image quality will be drastically improved, you can minimize the use of contrast media and X-ray dose for your patient with this technology. According to the pilot site in Japan, they succeeded in reducing X-ray dose by up to 30% compared to their normal system settings. This is still a pilot experience, but I believe the day will come soon when we can achieve worse contrast and X-ray dose reduction utilize this kind of real-time AI technology. So, ladies and gentlemen, here you can see a take-home message of my presentation. Based on the advancement in catheter technology, catheter interventions have been spreading to patients in need of more minimally invasive therapies. Therefore, medical imaging is evolving in accordance with device treatment advancement, and AI technology has started to be utilized for real-time imaging for less invasive therapies. So cardiologists should monitor their advancements for pursuing continuous improvement in daily practice. Thank you for your kind attention.
Thank you, Marza. First, congratulations on an extremely complex valve-in-valve transcatheter aortic valve implantation, complex in terms of clinical characteristics, complex in terms of access, navigating through the vasculature in a descending aorta that is dissected, complex in terms of the valve-in-valve placement. I think we cannot comment on this case. It is there are so many features, but I think in the interest of the technology and coming back to what we already learned from Nicola in the previous presentation, we learned about the dose tracking feature, we learned about the spot ROI technology, and now we learned about this AI enhanced imaging intensification. And maybe you can just quickly say, so how does it, you don't need to do a cine angiography in order to obtain this quality of image. It is purely obtained by contrast injection during fluoroscopy. Is that correct?
Yeah, I think so. But it's not commercial use now, so it's a future innovation.
Okay.
So that's why.
So it's something we can look forward to, but I think if this would arrive in clinical practice, I think we all would immediately appreciate its effect in terms of dose reduction and facilitating visualization.
But it's coming soon.
Unfortunately, we need to proceed. The next case may be even more complex. So I welcome Dr. Pasupati, and he will present on the latest echo fusion imaging in structural and PCI case.
Thank you, Stefan, and thanks for the organizers for inviting me. I have no conflicts for this talk. I'm a cardiologist from New Zealand. In Waikato, we cover pretty much this north area, do about 5,000 procedures with 4 cath labs there, and we are not a big country, but I was quite fortunate to trial the Canon's new AI tools. So pretty much in the next 10 minutes or so, you will see slightly space-age technology, which is pretty much using the dynamic device stabilizer for coronary stents, and also the echo fusion for structural heart disease using the AI technology. So to enhance a stent, we all know with time the coronary stents are getting thinner and thinner on the struts for trackability, maybe to reduce in-stent restenosis. But we need cath labs to actually cope with the technology so we can actually see the stents when we are implanting. And we still know there are some vendor stents that is very hard to visualize. So we are all familiar with the stent boost from a competitor that has been around for a while. And the other labs are now got stent enhancer from Canon and clear stent from Siemens. But they all give you very clear image on a static image. You have to do extra radiation because you need to acquire the image. There is a disruption on the flow because it has to be post-processed before the image comes up on the screen, and the images are static. To mitigate all of this, now we have a live technology. So with the live technology, if you all are used to Philips SyncVision, which has been around for about a decade or so, which actually used a live image to enhance it, but this is a third-party image and it still has its own nuances when it works. So Canon's come out with this DDS system, which we will look at, and using the AI technology, how this is slightly better compared to a couple of the other live views that are around, and it pretty much mitigates the negative components of the static views that we get from stent enhancer or the stent boost that we are used to. So dynamic device stabilizer, what is it? So the first thing with that is when you bring a stent in here, you look at the 2 little dots in the balloon. So a balloon or a stent, it doesn't matter. As soon as you see the 2 dots, the AI will pick that up. And when it picks the two dots, you can see the dots start stabilize. That means the motion that happens in the heart is reduced. So as soon as it's reduced, your stent is stabilized, and then it'll enhance the stent. Now that is the two components that the AI learns to do this, and then it'll do it for you. So it won't disrupt your flow, and you can continue with the procedure. So if you look at the image down here, so this is your live fluoro at the side, but on the second screen, you'll see the DDS screen. So you can look at it, you can ignore it, and just carry on like a normal procedure without disruption to the flow. So doing the DDS technology, all of this learning is done during the developmental phase. So this is done in the factory, and there are multiple images with the two dots that have been put through the process, and the AI is taught to figure out these two dots. And once you have done that, and then you come on to the clinical phase, it uses the two dots. It comes on a stent or it comes on the balloon to pretty much as soon as it sees it, it'll pause it, so your motion is reduced, and then it'll enhance the stent or the metal parts that are in its view. So that is how the DDS system works. So if you look at some examples where you are going to use the DDS system, first of all, it is very easy. So there is no post-processing, it's just a press of a button. As soon as you press the button, you're going to get two screens. One is your live screen still running, and on the second side, you're going to get the DDS screen. You can watch it or you can ignore it. Now, the images pretty much runs independent to your live screen, and pretty much it can be done on a fluoro or acquisition. So this is all fluoro images, but you can do them on the acco. So you decide to do an acquisition, it'll pick that up and then give you more enhanced. So you can use the DDS. If you see the first example here, there's a stent come in, and then there are two dots here, and there's another stent here. So as soon as your stent comes in, it'll not only stabilize your current stent, it'll enhance the previous stent, so you can do a back-to-back stent without even thinking of it. So that is positioning. When you expand your balloon, you'll get a much better idea at the maximum expansion, how much you had expanded, and then if you just want to look at your stent structure itself, just keep the balloon in there, the stent will actually get enhanced, and you can see the enhanced. This is all done simultaneously with no extra acquisition. It's running on a parallel screen for you. So what is the image price do we pay for all of this? Do we lose significant image quality compared to the static system like the stent enhancer or the stent boost? So these are real cases. So there's no magnification done here. So this is what we usually see on a fluoroscope. There is a balloon here, there's a stent here, this is what we see. This is what you'll see on your second screen. This is no magnification. The DDS actually will give you a bit of magnification, and this is a kind of image that you'll see, and this is just a fluoro image. If you decide that, God, it's my balloon sitting in the stent, and you do a quick acquisition, you may get this view, but in the DDS, you'll get this view. So there is no extra dose. It just comes up on the second screen, and the AI will immediately give it to you. Now, if you have a lot of time, you wait for the post-processing, and you can get stent enhancer, but that disrupts the workflow. So in this way, you just carry on, and this is the kind of screen that you'll see next to you as you are going through the cases. So this is just a quick example on a 51-year-old gentleman with an anterior STEMI. So this is just showing a screen setup. You have your hemo here. You have your reference screen here. This is my live screen, and then this is the DDS screen. You just press the D and it just come up. You can set it up the way you want in your own lab. So this is kind of a quick setup, and these usually works on a 15 centimeter magnification. That's when the DDS works the best. So here I put the first stent in the LAD. It's looking at these two dots. I'm coming with a second stent here now to place it behind the first stent, and it immediately enhances the first stent because there are two dots. And then I'm expanding the stent. You can see there's a little bit of under expansion here. And then when you take your balloon down, this is what you usually see on your workforce, on the fluoro, but this is what you'll see on the DDS screen. So the stent will immediately enhance, and you can continue to expand the stents as much as you want to. So that is DDS. And then use the same AI technologies to talk about echo fusion as well. So what is echo fusion? So people who have done structural heart disease will be aware with Echo Navigator, which Philips has had, and there's True Fusion from Siemens, and Echo Fusion is a new kid in the block with Canon. But there are differences in this. So when you talk about echo fusion, you need 2D live fusion. So a 2D live fusion, so Philips usually will give you a 2D, 3D live fusion, but in the Siemens, it is a live fusion, but you do not see the images on the screen. You see a dot, or you see the valve that you can draw, and that comes up on the screen. It is not live. The true version 2 will come with some live fusion, but current available system just gives you a dot. So while Canon has come into the market, what you are seeing is you not only see the image that is coming onto the screen live, that image quality is way better than the current vendors that are around. We pretty much have these systems in our lab. So with the AI deep learning, which is actually something extra that you get out with this system, you get further benefits from it, which is what we're going to look at in the next couple of slides. So what is echo fusion? Echo fusion is you have an echocardiogram where you're seeing the soft tissue, and you are bringing the soft tissue onto a radiation screen, which is what your fluoroscope, and you are superimposing it. That is echo fusion. Now, with the AI technology, the extra part you get, so if you have your Philips heart navigator, you know first you need to zero the bed. Then once you zero the bed, you need to do 2 orthogonal views to get the fusion on the right spot. If you don't do that, the fusion may come, but the fusion may be off. So with the AI technology, you do not need to do any of that. The AI detects the probe and it knows where in the space you are. You don't need to do any zeroing of the bed. Your workflow still carries on. It picks the probe and it'll just fuse the image for you. And through the case, it'll continue to pick the probe and give you the images where you don't need to go back and reset like what you have to do with the other technologies in case you've done a lot of movement. So that is pretty much the AI technology that the Canon offers. So with again, like what I told with the DDS system, this is also done in the developmental phase. The learning part is done in the developmental phase. So you look at multiple chases of the echo probes, and it learns the echo probe and decides where it is in the 3D space. And then when you come on to the clinical space, then it pretty much sees the echo probe, and then it sees the image that comes off the echo probe, and then it fuses onto the X-ray. So that is how the system works, and then you get the fusion image on the day. So if you look at a live screen here, so this is just a simple PFO case, no hemodynamics is used. This is an echo image. This is just a static to show your workflow lay. This is just the live fluoro, and you can see how this image has been fused onto the screen with the device. So if you look at the case itself, so this is a young female with a cerebral stroke. You may not need to use fusion for this, but I'm showing you the concept so you can understand. So you can see the SVC, you can see the IVC, and you can see the PFO tunnel. Generally, you will just cross blindly, knowing where you are. You'll just look at the echo. Now, when you get a fusion, you see the SVC, you see the IVC, you can even see the PFO tunnel, and you can just cross. So it's very easy to teach students where you are in space, where your tunnel is, and just cross through the tunnel. So that is the fusion image. You want to do a balloon sizing. Usually, we take a balloon, we inflate the balloon, and then we decide where is my waist, and we adjust the balloon. But here, you don't need to. You actually see the tunnel. You go in, you inflate, you get the size, and you can move on. So that it speeds your process that you are doing. This is the PFO closure itself. This device is actually pulled a little bit harshly, so you can see the device is slightly inverted. So if you want to recapture that and replace it, you can do that. So you can see the non-fused image. So whatever that is fused is whatever that is shown in the echo is a bit that fuses. Anything that is not fused, you will see it on the fluoroscope still at the same time. So this time you can see the PFO tunnel, you come and relax the left atrial disc, and then you put the right atrial disc, and the device sits there very nicely. This is a case with an 88-year-old gentleman who was concerned to have significant paravalvular leak. Now, I'm not going to show you the paravalvular leak part of it. I just brought on to show the fusion here. So if you do a short axis view, the short axis view of the valve is sitting like this. The short axis view is going into the screen. So your fusion image will also go into the screen. If you do a biplane here and you want to show the long axis view, you can see the long axis view is now fused to the valve itself. So the next stage is you put the color, you can see the paravalvular leak where it is, and then you can cross through the paravalvular leak and close it if you want to. So that's usually how the fusion works here. This is another young patient who's come for a balloon mitral valvuloplasty. So you are doing the septal puncture here. So usually, so this is what you get with the true fusion from the Siemens. You can put a dot, and the dot will come, but the dot is static. The dot doesn't move when you move the thing. So dot is static. So when you do a septal puncture, you have indented the septum, and you can see how the needle is past the dot. So here you are seeing both. You are seeing the dot as much as you are seeing the septum. You can indent. You can look at the point of the septum, anterior, posterior. You can do a biplane if you want to, and just cross right through the middle. So you will get the exact spot you want to cross. This is a BMB case itself. Sometimes people have problem crossing with the balloon, but it's very easy to teach the fellows that when you superimpose the image, you can exactly see where it is, where to cross, where is the ventricular part of the balloon opening on the inoe, then where is the atrial parts opening and doing the BMV. So this is just, you get the gist how you can use this and how you can expand this technology. So just to summarize this, deep learning provides a robust and consistent detection. It's constantly working with you. There is no operator input needed. You just use your pedal, you do your workflow, it just comes on the next screen. There's nothing more for you to do except just press one button. It's a very fast results. There is no dose penalty for this because this is what you do on a day-to-day basis. The consistency of this fusion is continuing to improve. So you can still go in the factory and get you to do more deep learning and then do a software upgrade. It will continue to learn as you're doing that, but not in the clinical day. It's all done on offline. And then pretty much there's a lot of wider clinical application as this technology develops. Thank you.
Thank you very much again for these impressive illustrations. Unfortunately, our time is up, but I need to ask you one question, and perhaps you can share your experience with the audience. Is it fair to say that this AI-enhanced use of fluoroscopy is able to completely replace cine acquisitions?
That's a very good question. That's actually for Asami, who actually presented the case, because mine is more on yes, for stent DDS part of it, it most probably can replace the cine acquisitions. As you saw the images, how good the images were. I don't know whether it'll completely replace. I think in New Zealand, an average weight of my patient is 120. It goes up to 200 kgs. Occasionally, I do want the odd cine. You saw it gives you even bit more clarity just for the fluoro to cine. But for majority of the patients, you can ignore the cine and you can go on fluoro.
So I think this benefit cannot be underestimated in terms of dose reduction, and I think we are certainly, as those applying these radiations on a daily practice, in our own interest, but particularly towards patients, very interested to learn more about this. I unfortunately need to close the session. The time has been completed, but nevertheless, I wish to thank the audience for the attention. Thank you for the very interesting presentations, and perhaps the three presenters also have time for you if you want to interact for further questions. Thank you very much.
Thank you.